41-year-old male patient came to the OPD with complaints of swelling above the left ear since 1 month. Initially, the swelling was small, approximately 1 into 1 centimeter, and later it progressed to its size of 4 into 4 centimeters. It was an insidious onset, gradually progressive, and it was not associated with any pain. So it was a recurrent, progressive, and non-painful swelling. There is no history of fever, no similar swelling elsewhere in the body, no redness, discharge or ulceration, no wound, or no history of significant weight loss. Patient had history of similar swelling in the same site 8 months and 4 months ago. Both the time it was operated. Coming to details of the cervical listing, in April 2025, the patient underwent primary surgery for the scalp swelling, and on histopathology, it was given as infected epidermal inclusion cells in the frontotemporal region. After that, the patient presented to us in the OPD in August 2025 with first recurrence, and after excision of that on histopathology, it was reported to be paraganglioma. Patient was lost in follow-up, and he only came with his histopathology report at a later stage. Second recurrence was the current case, where the swelling was approximately 4 into 4 centimeter, and it was fixed to the overlying skin. So there were 2 recurrences at the same anatomical site with progressive increase in size and fixity to the skin. Vital parameters of the patient were stable, and the ECOG score was 1, and the patient was well built and nourished. On local examination, there was a 4 into 4 centimeter solitary swelling, which was spherical in shape with well-defined borders. Surface was smooth. Scar from the previous excision was seen. No evidence of any punctal pigmentation or redness. On palpation, there was no local rise of temperature, no tenderness. Size was confirmed to be 4.2 to 4.5 centimeters. Surface was smooth. The swelling was soft in consistency, non-compressible, no regional infertility. The main clinical point was that it was fixed to the overlying skin, which suggested the involvement of dermis or epidermis. We proceeded with the clinical laboratory investigations, and all the investigations were found to be normal, and anesthesia PAC was accepted under ACA grade 1. We had advised for NCCT, but however, due to financial constraints, patient could not undergo. So we had taken an ultrasound and X-ray skull. X-ray skull suggested no involvement of bones. And the ultrasound, it was a well-defined heteroechoic lesion measuring 2.6 into 2.1 centimeter in the posterior auricular region. It was located in the subcutaneous plane, and it was extending up to the skin. Central cystic areas was present, and vascularity was predominant along the periphery. Systemic examination was found to be normal. So we proceeded with the surgical procedure. What was proposed was wide local excision, and the defect which resulted was covered with a multiple pinwheel flap. First, the flap marking and design. So this was the tumor or the resultant defect. So we have taken points 90 degrees to each other. Then we have taken midpoint of these 2 points around 270 degrees, and we have marked the location like this in the shape of a pinwheel. This was the pictorial representation, and this was the marking notation. So next we have proceeded with the wide local excision, and 5 mm margin was left, and the resultant defect was 4 into 4 centimeters. So this was the wide local excision, post the excision. Next, the flaps were elevated down to the level of area from neurotica, and the edges were undermined. After undermining the edges, this was how it looked. Then the 4 flaps were rotated in a pinwheel fashion or a camera shutter configuration. This is the flap advancement stage. And after placing a monoclinic suture in the middle, we have resulted in the shape of a pinwheel. We have sutured around the lens. Tension-free closure was achieved, and the tension was redistributed across the 4 radiating suture lines. We have placed a drain also. Post-surgery, the follow-up was done at 2 weeks and 3 weeks, and wound healing was found to be satisfactory. So this was the patient at 2 weeks and 3 weeks of follow-up. Currently, the patient is being followed up regularly. So after the excision of the tumor, we have sent it to the histopathology, and on microscopy, tumor cells were found in nodules, sheets, and trabecules. Round to oval cells were there with salt and pepper chromatin. Cytoplasm was scanned with areas of necrosis present, and 5 to 6 mitosis were there in 5 to 6 hypophiles. So the initial impression which was there before IHC markers were markers in carcinoma in the left temporal region, paraganglioma and melanoma. And we have proceeded with the IHC panel as shown. Each of the IHCs, CK20, EMA and PAN-CK, but the epithelial markers, CK20 especially for Merkel cell carcinoma, acid was negative, for this were rolled out. S100 and HB45 both were negative. These were the melanocytic markers which ruled out melanoma. Chromoplanin was negative, which ruled out a neuroendocrine tumor, paraganglioma. LCA was a lymphoid marker which ruled out lymphoma. CD99 was a Ewing sarcoma or peanut marker which was negative. Only Ki67 was positive. So what is Ki67, which is more than 50% mean? So it means that the tumor cells are actively dividing and it indicates a very high proliferation rate, suggesting that the tumor is fast growing and highly aggressive. So the features were suggestive of a highly undifferentiated tumor, and further IHC workup was advised, and the patient was referred to higher center for IHC workup. The patient has underwent 15 cycles of radiation and is currently doing therapy. So discussion. So scalp lesion removal with primary closure demands surgical ingenuity, especially for defects which are greater more than 3 cm in size, and it requires elaborate flap designs. A practical multi-flap variation of the previously well-established theme was the Pinwheel Flap or the canvas shutter configuration. Full 360-degree mobilization of the surrounding tissue was done in this case versus the linear closure, which moves the tissue only in 2 directions. The scalp has essentially no elasticity, and a complete flap mobilization is necessary even for shock tissue advancement. The specialty of Pinwheel is that it avoids excessive sacrifice of the normal tissue. Advantages of this Pinwheel Flap is that minimal undermining was done. There was simplicity and easy design. No excessive excision of normal tissue was done. Only the minimal dog-ear which resulted can be recontoured at a later stage, and the tension was distributed along the 4 radiating suture lines. The clinical results are that the Pinwheel Flap is usable anywhere on the scalp because it has uniform mobility and blood supply, rounded edges with a broad base and smaller rotation arm and fewer complications. Edge necrosis encountered in only a small % of cases. Scalp vascularity, inelasticity, and thickness account for the clinical success of this flap. So the other reconstruction flap options which we had were limber flap, a double rotation flap, 3-flap technique, and double advancement flap. However, we proceeded with the Pinwheel Flap in this case because 2 prior excisions was done, which had led to fibrosis and wound tissue elasticity and rotational mobility. Repeated dissection damages the local perforators, which leads to unreliable blood supply, and there is a risk of necrosis. The lesion was fixed to the overlying skin, and larger irregular defect was there, which resulted in less adjacent tissue which was available. Adjacent tissue may also harbor microscopic residual disease from previous incomplete excisions. It also had geometrical constraints because it was very close in proximity to the hairline, ear, and the orbital rim, and it restricts the large arc of the rotational flap which was required. So, and also the rearranged tissue planes obscure the future recurrence, which was critical in quite later in patient. With this, I conclude my presentation. These are the references. Many thanks. Special thanks to the Department of Pathology for